I want to thank FSR for organizing this patient conference. I think it's a great opportunity for you guys to learn a little bit more about sarcoidosis and hopefully talk to other people with sarcoidosis. FSR is an amazing organization and has really propelled research in the field. And if you can, I encourage you to support it. So my topic today is complications of sarcoidosis, including depression, sleep apnea, and fatigue. I really like this topic because these are issues that really impact quality of life and really don't get discussed very much. So that's going to be my focus for the day. So as I said, sleep disordered breathing, depression, and fatigue is what I'm going to talk about. I really like this diagram because it talks about how sarcoidosis is more than just your lung disease or your heart disease. There's lots of different things that go into sarcoidosis. So this is a Venn diagram that shows how things like depression, fatigue, sleep disturbances, small fiber neuropathy, which some of you may have, and shortness of breath, all of those things sort of can affect each other and usually present simultaneously. So the first topic I want to talk about is sleep disordered breathing. And the most common form of sleep disordered breathing is sleep apnea. And some of you may have heard of sleep apnea or have sleep apnea and are treated for it. Interestingly, in patients with sarcoidosis, there's a higher prevalence of sleep apnea than the general population. So in patients with sleep apnea, different studies have reported different rates, but anywhere between 17 to 67%. And this is a really important thing to sort of distinguish because some of the symptoms of sleep apnea overlap with the symptoms of, for example, pulmonary sarcoidosis. And so the question is, why is there more sleep apnea in patients with sarcoidosis than in the general population? We don't really know the answer to that, to be honest. Some theories that we have is, well, there's some maybe more weight gain because of steroid use in patients with sarcoidosis. Maybe some patients have sarcoidosis that involves the upper airway, and/or lupus pernio, which Dr. Mezzarati showed some pictures of. So maybe that might be a risk factor. Other people think that maybe it's lung scarring itself and the effect that it has on the air tubes that go into the lungs that could cause, that could be the reason for a higher prevalence of sleep apnea. The next topic I want to talk about and share with you what we know about is depression. So we know that depression is pretty common in patients with sarcoidosis. So again, depending on the study you look at, various rates, so between 46 to 66%, that's pretty high. That means the majority of patients with sarcoidosis have depression. And interestingly, different studies have shown that depression scores, so there's various tests for depression, questionnaires that patients can take. When patients take those questionnaires, their scores for depression, so the higher the score, the more likelihood they have depression. There's higher scores in sarcoidosis patients than the general population. It's even higher than patients with cancer. There's a study from Germany that shows that depression scores are higher in patients with sarcoidosis than patients with cancer, who are hospitalized, to make it even worse. And patients with cardiac disease, like heart failure, things like that. The effect of this has been shown, at least in one study, to be higher in younger patients. So the younger you are, the more likely, interestingly, to be depressed. So in this specific German study, if you're between the age of 51 and 61, you're more likely to be depressed. If you're younger than 41 years old, you are more likely to have anxiety. So those are important findings. And the important thing about depression is that studies have shown that it has the best correlation for quality of life. So it's better than your lung function tests. It correlates better with your quality of life than lung function tests, and your doctor's perception of your disease. So you could have horrible lung function tests, but if you're not depressed, you're likely to have a better quality of life. And I thought that was pretty interesting. So studies have shown that in patients with sarcoidosis, the predictors of depression include female gender. Interestingly, perceived lack of access to care. So a patient's perception that they don't have access to good care is a predictor for depression. Shortness of breath itself. And then the number of other illnesses, medical illnesses you have, like for example, diabetes, high blood pressure, heart problems, things like that. So the more of those other types of diseases you have, that tends to correlate better with risk for depression. What we don't know is if you take a patient with sarcoidosis and you treat their depression, does that improve their quality of life? You know, we don't know the answer to that because that study's never been done. And we don't know why, the other important question we don't know is why do patients with sarcoidosis have a higher rate of depression? What is the cause of that? We don't know the answer to these really important questions. So what I usually, and part of my evaluation for patients, you know, is besides asking them about their shortness of breath or palpitations or kidney stones or pain and fatigue, I also ask them about these questions. And if you have these symptoms, I really highly suggest you talk to your doctor, the one in charge of taking care of your sarcoidosis, and at the least with your family doctor, your primary care doctor. So symptoms of depression include feeling sad or having a depressed mood, loss of interest or pleasure in activities that you once enjoyed, changes in your appetite, which can manifest as, you know, changes in weight. If you're having trouble sleeping or you're sleeping too much, that can be a sign of depression, loss of energy. You know, all of these things are signs and symptoms of depression, and I would have to say probably most people with sarcoidosis may experience one of these symptoms at some point in their disease. So if you have any of these symptoms, please talk to your doctor. It's really important. And it's really important, again, we don't know the answer to whether treating depression helps or not or changes the quality of life, but I think it's worth it to get treated. And treatment can be many things, and we'll discuss that, you know, later on. Treatment can include medications, but there's other things that treatment can include. I frequently refer patients to therapy and counseling because sometimes I think those, even support groups, sometimes those things are just as effective for patients than as medication. So if you have these symptoms, talk to your doctor. It's really important because it impacts your quality of life. All right, so what I'm going to spend most of my time talking about is fatigue. And the reason I want to spend most of my time talking about this is because this is the symptom that invariably every patient I have complains of. Everybody has fatigue. So some of the issues with fatigue is no one's actually really defined it clearly. In sarcoidosis, no one's really given a clear definition of it, and even in other diseases and illnesses, it hasn't been really defined clearly. In general, the way I think about it, and I ask about it, is if you have do you have a state of physical or mental weariness? Again, 50 to 70%, depending on the study you look at, of patients with sarcoidosis experience or report fatigue. That's a lot. And in some people, it can be very disabling. I've had patients come to me seeking treatment, not for breathing problems or heart involvement or other things, important organ involvement, but primarily fatigue. Usually what we think about in terms of the cause of fatigue is, is it the sarcoidosis itself, but other things like weight gain, again, that you can experience from steroid treatment, getting out of shape because you can't breathe and so you haven't been doing much physical activity. Sleep apnea itself can cause fatigue. Depression can cause a patient to feel fatigued, and medications. So, all right. So I borrowed this concept from Mark Judson up in Albany, and I think it's important. He talks about fatigue and sarcoidosis in two different ways. One is sarcoidosis-associated fatigue. So maybe not the sarcoidosis itself, but fatigue from any cause that a patient with sarcoidosis happens to have. So for example, causes of fatigue we know for certain are obstructive sleep apnea, which we talked about, depression, which we talked about. So thyroid disease is a really common cause of fatigue. And then, some patients who take steroids for a long time get a condition called adrenal insufficiency, where your adrenal glands, which are responsible for releasing cortisol, which is a hormone, can get suppressed when you're on steroids for a long time. So that itself can cause fatigue. And it's really important to distinguish the symptoms between sarcoidosis-induced fatigue and these other things. And so, for example, when I have a patient that comes in to my clinic complaining of fatigue, the first things I do is I ask them about these other things. So I might do some blood tests to look at their thyroid, to look at their adrenal glands, maybe check some vitamin levels, make sure their blood counts are okay, because all of those things can cause fatigue. And then I ask them about symptoms of depression, so I might have them do a questionnaire to see if they're depressed or not. And if that questionnaire comes back positive, then we might talk about medications and therapy, support groups, those sort of things. And I most invariably send them for a sleep test to see if they might have sleep apnea, because if they have sleep apnea, getting treated for sleep apnea might improve their fatigue. So that's, and other things besides this that I also think about is medications. So some of you might be on methotrexate, and if you talk to anybody who takes methotrexate, they'll tell you the day after they're just wiped out. I have a patient who is exhausted for days with 15 milligrams of methotrexate, but when I decreased his dose to 12.5, he was able to do whatever he needed to do. So medications that you're on could also impact your experience of fatigue. And other things, it's also important to think about the other things that are happening in a patient's life. For example, I have a patient who lost her young daughter unexpectedly and has been depressed and fatigued essentially ever since that's happened. So we've been focusing not so much on the treatment of her sarcoidosis necessarily to alter her depression and her fatigue, but to seek grief counseling and things like that. So those are important things to consider. And then, so we talked about sarcoidosis-associated fatigue, but then we think that there's also sarcoidosis-induced fatigue. So what that means is that there's something about sarcoidosis itself that causes you to feel more tired. And most likely, as Dr. Mesrati mentioned, when you have sarcoidosis, you have a release of cytokines, which are inflammatory chemicals that are circulating in your body, and maybe that has something to do with the fatigue. Dr. Judson calls it a parasarcoidosis, so it's not the granulomas themselves that is causing this, but it's a downward effect of those granulomas. And what we know, at least in clinical experience and maybe a few studies, is unfortunately this kind of fatigue doesn't respond to the prednisone, the methotrexate, the leflunomide, the azathioprine, infliximab, all of those drugs that patients take for sarcoidosis. And that's been shown in multiple studies. So we know that, and that's, we know that in these studies and also clinically, you know, when these drugs are not the answer. The prednisone is not the answer to this kind of fatigue. So we talked about a little bit about how we don't have a definition for fatigue, but you know, can we measure it? Is there a way to kind of figure out, you know, a patient's, whether they're fatigued or not and how bad it is? Unfortunately, there's no objective test. So what that means is there's no blood test I can do, there's no imaging study I can do to measure whether you have fatigue or not and how bad it is. But there are questionnaires, and those are called patient-reported outcome measures. And probably, I'm sorry, my slides are out of order for some reason. This is the one that I think is probably most well known for fatigue. It's called the Fatigue Assessment Questionnaire. And if you want to look this up, and I encourage you to do that, if you go into Google and type in sarcoidosis and fatigue assessment scale, you should get a PDF link to this questionnaire on a website called ildcare.org. And I encourage you to find it and to take this questionnaire. And this is a questionnaire that I like and I administer. So for example, if I have a patient who complains of fatigue, I'll have them take this questionnaire. We'll write down the result, and then, you know, as we sort of, you know, do the sleep tests and get that sleep disorder treated, as we initiate our exercise regimen, over time, I'll have them repeatedly to take this questionnaire to see how their fatigue is doing. So I think this is a really useful tool. I want to talk about fatigue as a vicious cycle. So, and again, you guys understand this way better than even I do. And I'm going to use this little mouse here to kind of point, to go through this diagram. So you have a patient with sarcoidosis which usually causes some muscle strength or respiratory functional impairment. It causes fatigue. It causes anxiety. And so those things sort of lead into shortness of breath, which can lead into reduced exercise capacity, and eventually physical inactivity, which leads to decreased social participation, maybe depression, which causes more deconditioning, which can lead to more reduced exercise capacity, and overall, the point is that it leads to impaired quality of life. So this is a vicious cycle. And you know, what are the treatments? I guess that's probably what you guys are wondering. I'm painting this like really bleak picture. So what are possible treatment options? There have been some studies that have been done to look for treatment options for fatigue. And this chart sort of summarizes some of these. So an anti-malarial agent like hydroxychloroquine, some of you guys might take that for like joint sarcoidosis or skin sarcoidosis. That's been, has been studied, and use of this agent has been associated with less fatigue. There's one study that shows that. Some of you might take infliximab or Humira. That's been reported. Again, these are not great studies where we randomize patients to you know, placebo and then the drug and compare the two groups, but it's been reported, so these are options. And then probably the group of drugs that has been studied the most for fatigue are called neurostimulants. And so there's 3 that are listed there. Most commonly, these drugs are the ones that are usually used for patients with ADD or ADHD. Some of you might have family members or children who are treated for ADHD. So those same drugs have been studied for fatigue and sarcoidosis, specifically for sarcoidosis, and these are good studies and have been shown to be effective. So if you're really, you know, struggling with fatigue, these drugs are a potential treatment option. Again, unfortunately, these also are drugs that are like very controlled substances, they're scheduled drugs, so they have their own drawbacks. But if your fatigue is disabling, these are potential treatment options that you should talk to your doctor about. One other drug is called modafinil, which is a drug that was developed for long-haul truck drivers who drive at night to keep them awake, and so they don't fall asleep at the wheel. So that's another drug that's been studied in sarcoidosis-associated fatigue. That's another treatment option, and it doesn't potentially have the same side effects as some of the neurostimulants that are used for ADHD or ADD. Let me just go back to this slide. I apologize, for some reason my slides are out of order. So in general, I want to go through this algorithm to show you how we like to approach patients with fatigue. So first, the most important thing is, do we have good control of the sarcoidosis? So if they have pulmonary sarcoidosis or skin sarcoidosis, have we controlled that very well? That's step one. So that's really important. If we haven't done that, then we need to work on that. If we have, then the next step is to evaluate for coexisting diseases. And the two most important coexisting diseases, again, as I mentioned earlier, is depression and sleep apnea. And to also rule out things like thyroid disease, and if a patient has thyroid disease, to make sure that's under good control, things like that, anemia. So again, I mentioned, looking for other things like diabetes, thyroid function. If you find that they have these other coexisting conditions, then we treat them. So if you have depression, you treat the depression. If you find that the patient has sleep apnea, we treat the sleep apnea. That's step one. Step one is to find these other coexisting conditions and to treat it. So again, as I mentioned that, if the fatigue is still present after you've done all of those things, then we consider these other drugs that I mentioned, the neurostimulant drugs, like methylphenidate and modafinil, and things like that. So that's sort of the algorithm I go down. In my personal experience, I don't use those neurostimulant drugs at all. I can't remember the last time I prescribed them, because most of the time what we find is that patients have sleep apnea or depression or something else going on, and if we treat that, their fatigue gets a lot better. I recall a patient I had who came to me, he had pulmonary sarcoidosis, and he came to me and he said, Dr. Patel, I can't function, my fatigue is horrible. He told me he was a truck driver, and so we did the sleep apnea test, and we did the depression test, and all those tests came back negative. So I was like, man, this is, I don't quite understand why he's so fatigued. His disease is very well controlled. It's pretty minimal. So I asked him more about his job. He told me he works 80 hours a week, and all of his shifts are at night. So, that's pretty, you don't need a physician to tell you that that probably affects your fatigue. And in fact, his wife had been telling him that for a long time. So I asked him to switch, maybe cut back on his hours and shift to daytime work, and his fatigue disappeared. So again, I can't remember the last time I prescribed these drugs, because most of the time we can find ways to help patients' fatigue. So. All right, so before I finish, I wanted to show you guys two slides, because I want to tell you guys what you can do to help your doctors figure out what your fatigue could be due to. So this is useful information that you can collect before you go to see your doctor and talk to them. So try to better characterize your fatigue. Do you know, is there a particular time of day that it's worse, like in the evenings? Is there particular activities you might be doing? Are there other symptoms accompanying your fatigue? So for instance, if you feel like you're really short of breath when you're fatigued, maybe it's not fatigue, maybe it's you're really short of breath. So those are important things to think about. Correlation with medication. Does your fatigue, come on, the day after you take your methotrexate? Those are important things to think about, and I encourage you to jot those observations down so that you can tell your doctor about those things. And then also think about what are other things going on in your life that are could be contributing to your fatigue. Do you have a really stressful job? You know, are there problems in your personal relationship? You know, do you have a mother who's really sick and you're the primary caregiver? To think about those things, to jot those things down, and those are really important things to tell your doctor. Your doctor should know what are about the psychosocial stressors in your life. Those are important things. If you have a partner, ask them to monitor for snoring and apnea. Apnea means that a person has stopped breathing. So usually a partner will notice that the patient has stopped breathing, and that's a really important question to ask your partner. Do I stop breathing at night? And then also it's really important to look at your sleep habits. So, you know, if you get 3 or 4 hours of sleep a night, you go to bed at 2 a.m. and you wake up at, you know, 5 in the morning, those are all important things. So jot down your sleep habits, ask your partner about snoring and apnea, and take this information with you to your doctor's visit. So I told you guys about depression and sleep apnea and fatigue, and given, at least for the fatigue, we have some treatment options, but what are the other things you can do? There's not a lot of studies or evidence for these things, but this is from my clinical practice and what I've noticed what patients really respond to. So for example, things that I recommend, you know, if your doctor recommends that sleep apnea test, go and get it. And if you're positive, use the CPAP machine. It will make a difference. I know the CPAP machines are not great and hard to get used to, but use them. It will make a difference. I refer patients to counseling and therapy for depression and mood disorders a lot, because I don't think depression should be treated with medication alone. I think therapy is really useful. Work really hard on the diet. I think diet makes a huge difference. You know, if you're not sure what to do, maybe talk to a nutritionist. I encourage my patients to exercise daily. And I know that's hard if you're short of breath, if you're on oxygen, things like that, but to find something they can do every day. So I'm not talking about, like, you know, I tell them to start with 10 minutes total of exercise a day, if you can, and to do it consistently. This seems to really help fatigue. I had a patient who came from out of state who was taking narcotics, all of these other horrible drugs to treat basically fatigue. And when we got him off those drugs and got him on an exercise regimen, he got a lot better. I know that's not always possible for everybody. So the type of exercise that I find a lot of patients respond to is water or exercises, because it tends to be easier on the joints and maybe doesn't make it as, maybe it's a little bit easier than on patients who have shortness of breath. Patients seem to respond to water aerobic exercises really well. If it's possible to try to lose weight, I know that's a huge challenge in sarcoidosis. I have had a few patients do that successfully, and it's really helped their fatigue significantly. Meditation, and then joining a support group, I think that can be really helpful as well. So those are my suggestions in addition to the other things we talked about. So I'm going to stop there.